Now, in terms of auscultation, the murmurs that are crescendo, decrescendo are both aortic stenosis and IHSS. Crescendo means louder, decrescendo means softer. Lub, dub, lub, dub. That's both of them in intensity. Now that's different from aortic regurgitation, which is simply decrescendo. Because the blood gets shot up out of the aortic valve. The blood gets shot up. Lub, you don't hear anything. And then blood comes back down on you in the ventricle. Lub. 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 So what you basically hear is cut down on my atropine, sorry. I'm seronegative in every way, it's okay. And that's the decrescendo. Decrescendo. I knew that made the list. Okay. Murmur is the aortic regurgitation. Now, mitral regurgitation has blood regurgitating backwards the whole time. So you don't hear a lub or a dub. All you simply hear is one sound. One sound, obscuring both S1 and S2. Is that holosystolic or pansystolic? It's the same. Holosystolic or pansystolic, obscuring it. So instead of lub, dub, lub, dub, you just hear as one sound through mitral regurgitation. Now, squatting and leg raise put more blood into the heart. Valsalva and standing, less blood in the heart. What is the pressure in the left atrium? What is the pressure in your left atrium right now? The vena cava are bringing blood back into the heart. Now this is exaggerated because the vena cava are essentially behind the heart. So you don't really see it. But blood is being returned back here, and blood is being returned back here into the right atrium. What is the pressure right now in your right atrium? 5 is not right now. 5 is when you're lying flat. 0 right now. 0 pressure in your right atrium. When you're standing, it's almost subatmospheric sometimes. So when you're standing, it can be subatmospheric. What happens to pressure in here during a Valsalva? Does it increase or decrease? In? This is the essence of it. Valsalva. You're exhaling? Yes? But you're not letting air out. So the pressure in here increases. You're increasing pressure in the intrathoracic space. In here, this whole area, in the thorax, you're increasing pressure. That's why nobody does a Valsalva, because it takes 20 minutes to explain it to someone. I tried to do it to the other guy, and the guy's a baker, right? He's a baker with mitral valve prolapse. You go to the guy, do a Valsalva. He goes, what? I said, do a Valsalva. He says, is that like a cannoli? Do a Valsalva, you know? Or you say, do a Valsalva. What's that? Exhale against the closed glottis. What are you talking about? Make like you're having a bowel movement. Why would I want to make like I'm having a bowel movement? Oh, be quiet. You know what I mean? It's too long, you know? Exhaling against the closed glottis increases pressure in here. Normally, pressure here in the right atrium is 0 when standing up. Blood just goes up into the heart and basically just falls into the heart. There is no pressure pushing it back into the heart. There is no pressure pushing the blood back in here. So if you increase this pressure in here, it keeps the blood backwards, pushes it backwards this way and that way. So if you increase the pressure in the intrathoracic space, there's no pressure pushing blood back up in the vena cava. So a Valsalva simply pushes blood out of the thorax. And that's why there's less blood in the heart. If you go from squatting, and all of a sudden you go from squatting to a standing position, you open up those big capacitance vessels in the legs, and blood pools there. Pressure is 0 in the venous system as it enters the heart, because there's nothing pushing the blood back up there. It gets to the end of its cycle. It's like a roller coaster. The roller coaster starts and goes, but by the time it gets back to the end, it basically just sort of falls into place at the end, because it's just weight based on gravity and going around, like skiing. It's like skiing at the end of the ski trail. There's no kinetic energy. Less blood in the heart. When you do squatting and leg raising and put more blood into the heart, do you have more murmur here or less murmur? Increased murmur or decreased murmur? Increased, decreased murmur. That's good, Oscar. That covers both options. In decrease. When you put more blood there, you put an increase in murmur. Look at it this way. I told you to look for the pregnant woman, right? And the pregnant woman has more blood volume. And when the pregnant woman has more blood volume, there'll be more blood to go through the stenotic valve. More blood, more murmur. Pregnant woman, more blood, more murmur. Preload reduction. Preload reduction is like doing a Valsalva. Preload reduction is like doing a Valsalva. Preload reduction is like standing. Preload reduction, you get less murmur. Of course you get less murmur, because that's why we treat this with preload reduction. Because preload reduction is like doing a Valsalva. A Valsalva is like giving a diuretic. The maneuvers follow the auscultation based on these same 3 principles. Preload reduction, inotrope, afterload reduction. It's the same idea. That's why here, aortic stenosis is treated with preload reduction, so it gives a decreased murmur. Mitral regurg gets preload reduction, decreased murmur. And aortic regurg, decreased preload. Both of them. Every single one of these gets treated with a diuretic. Since all of them can be treated with a diuretic, it implies that if a diuretic, which decreases preload, makes them better, it implies that Valsalva will make the murmur less intense. As a matter of fact, all of the left-sided murmurs get more intense with more blood and less intense with less blood. More blood, more murmur, less blood, less murmur for all the left-sided lesions except IHSS and mitral valve prolapse. And that is the point. All of them. More blood, more murmur, less blood, less murmur, except IHSS and mitral valve prolapse. The treatments follow this. Look at it this way. Every single one of these gets managed with preload reduction. Every single one of these gets a diuretic. Every single one of these improves with Valsalva and standing. The treatments and the auscultatory maneuvers follow each other. Now, IHSS, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. What is the most common symptom of hypertrophic cardiomyopathy? What's the most common presentation of a hypertrophic cardiomyopathy? Sudden death? The most common presentation? So can you tell me what brought you here today? Well, Doc, I woke up this morning and I was feeling mighty dead. I got to tell you. I couldn't feel like doing anything. I didn't feel like doing anything. I felt really dead this morning. Let me tell you, I felt really dead. I woke up dead this morning. Well, it's hard to have a specialty based on IHSS then, right? Well, here's my collection of dead patients. They're all dead. Chief complaint. The least common presentation is sudden death. But it's certainly the most dramatic, isn't it? Nobody says, today Michael Jordan returns to basketball. He ran across the basketball court and he got short of breath. No one says that. You remember this. Dribble, 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 shoot, score, die. It's the most common cause of sudden death in healthy athletes, but the most common presentation is not sudden death. What's the most common presentation? Syncope is the second most common wrong answer. Hypertension, no. Shortness, not arrhythmia. Shortness of breath. Yes, unfortunately, if it can only be so simple that they just let you fill in the answers. Shortness of breath. Syncope. Priap. Shortness of breath. Hey, look at it this way. Look, the big floppy heart from dilated cardiomyopathy, from multiple MIs, or alcohol, or the big dilated cardiomyopathy with the heart with this little teeny little pissy little 15 or 20% ejection fraction from alcohol or adriamycin MIs or Chagas disease. If you're trying to get blood from point A to point B, and you have a big floppy heart filled with blood that beats like this, and no ejection fraction, you can't move blood forward. The same way, if you have a big, thick, hypertrophic heart that has a huge ejection fraction of 85% ejection fraction, but the heart is so big and thick and hypertrophic, I feel like I'm drawing an endometriosis here or something. So, if you have a big, thick, hypertrophic heart that the heart beats like this, ooh, and empties out, big, strong, muy macho heart with a huge ejection fraction, but it never relaxes to receive blood, you can't get blood moved from point A to point B. It's the same thing. The big floppy heart that's filled with blood and goes, or the big, strong, muy macho heart that goes, wham, big ejection fraction, but never relaxes to receive, they're the same. So if they are the same, surprise, 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 shortness of breath is the chief complaint on both of them. It's the same idea. No blood goes forward. Syncope and sudden death sometimes. Dyspnea. Okay. The only thing that it has in common is that basically echocardiogram is the best initial diagnostic test for all of them, and cardiac catheterization is the most accurate diagnostic test for all of them. IHSS. More blood, less murmur, less blood, more murmur. Why is that? Is because you have this heart going over here to the aorta, and normally you should have, normally you should have the exit path here, and what you have is septal hypertrophy, but it's asymmetric septal hypertrophy. Normally you should have blood being able to freely exit the left ventricle, but now you have this asymmetric septum here. And this asymmetric septum is getting in the way. So anything that makes the heart smaller increases the obstruction. Anything that makes the heart bigger pushes away that obstruction. Anything that makes the heart bigger pushes away this obstruction and makes it easier for blood to get out of the ventricle. Anything that pushes this away opens up the heart. Anything that makes the heart smaller closes up the heart and pulls this together. Asymmetric septal hypertrophy, getting in the way. Hypertrophic, yes, that's hypertrophic. It's obstructive. Cardio, heart. Myo, muscle. Pathic, bad. Bad heart muscle. Or idiopathic hypertrophic subaortic stenosis. They're all the same thing. Big heart, small heart. Less obstruction, more obstruction. Look, 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 look. Big heart, small heart. Big heart, more blood. Small heart, less blood. Less obstruction, more obstruction. When you exercise, the heart empties more fully. It contracts more fully, more obstruction. When you're dehydrated, the heart empties more fully, more obstruction. When you use digoxin, more obstruction. Diuretics, dehydration. Exercise, more obstruction. When do you treat these two entities with preload reduction? When do you treat both of these with diuretics? IHSS and mitral valve prolapse. When do they get diuretics? Never. They never get diuretics. Diuretics here would be dangerous, death. They never get diuretics. What's the best initial therapy for IHSS? Fluid? Well, yes, but you can't just say drink, drink, drink. Drink 6 Mountain Dews a day. Beta blocker. Beta blocker. Beta blocker. Beta blocker. Oh, beta blocker. Which of these valve lesions gets treated with a beta blocker? Huh? Which of these with a beta blocker? None of them with a beta blocker. None of them get treated with a beta blocker. None of them get treated with a beta blocker. They don't get treated with a beta blocker. These do. Which gets treated with ACE inhibitor? IHSS or mitral valve prolapse? Think, think, think. Don't you give up? Neither of them. These get treated with ACE inhibitors, and these never do. These get treated with beta blockers, both of them. And here, finally, sometimes digoxin. Do you catch my drift here? Look at this. Look, the treatment is exactly the opposite. The maneuvers are the opposite. It's saying the same thing twice. The maneuvers and the treatment follow each other. The predominant effect of the beta blockers in helping IHSS is because of what? Why do the beta blockers make IHSS better? Negative inotropic activity is the most common wrong answer. I was once young and foolish like you. And I used to think that too. Huh? The beta blockers, you think it's like this. You think the beta blocker's doing this. Oh, it's preventing the heart from contracting so much. It's not contracting so much. It's the same thing as why you thought not to use them in congestive failure. Oh, don't use that beta blocker. It's like succinylcholine for the heart. But it's not. The major effect of the beta blocker on IHSS is on the heart rate. Filling in the blank. Priap. Heart rate. The major effect is upon the heart rate. When you have the beta blocker on, filling, less obstruction. It fills, less obstruction. Are we clear? Not this whole thing about decreasing the force of contraction. That's what I thought too. I used to. I was lied to. I was mistook. I was bamboozled, the same as you. Heart rate is the major effect of beta blockers. Decrease that oxygen consumption. Increase the filling time. Prevent the obstruction. Very, very cool. Very cool. Now, mitral valve prolapse is the murmur of mitral regurgitation. Mitral valve prolapse is mitral regurg, yet everything about mitral valve prolapse is pretty much exactly the opposite. First of all, we said that the most common etiology of mitral regurg, we said was infection and infarction, ischemic heart disease. Ischemic heart disease never causes mitral valve prolapse. You don't get prolapse from ischemic heart disease. You get mitral valve prolapse because you just got it. Congenital. It happens. Extra floppy valves. And it's not from all the Ehlers, Danlos, and Marfans you think is out there. It just happens. We said that mitral regurg presents almost exclusively with the shortness of breath and Ralls and edema and S3 gallop. That's presenting the same as congestive heart failure. What's the most common presentation of mitral valve prolapse? What's the most common presentation of mitral valve prolapse? Can be actually nothing, but we wouldn't have much of a discussion then. Could be nothing. Patient presents with nothing. Okay, it's time to go home. That's it. Short day. Okay, we have two types of valve diseases. This valve disease, everybody's dead. In this valve disease, everybody has nothing. It's like Goldilocks and the Three Bears. This valve disorder has too many symptoms. This valve disorder has too few symptoms. This valve disorder is just right. So we got it here. Don't do that. You're going to ruin my specialty, brother. Go on and do that tonight. When it has symptoms, he's right that it can be asymptomatic. It often is. Okay? But the thing is that when it has symptoms, what's the most common symptoms? Huh? Chest pain? Pain? Palpitations? With prolapse? You get pain and palpitations? With prolapse? Bring your umbrella. Didn't they tell you to do that? For this, he backs up so everybody can see. That's good. Okay, so they should have brought you. Bring your umbrella. You're seeing Dr. Fisher. Okay, so the thing is, mitral valve prolapse does give you pain and palpitation. What else? Mitral valve prolapse. Atypical chest pain. Dizziness. Pain, palpitations, and syncope. Sometimes, rarely. Pain is the most common thing. Atypical chest pain with the prolapse and the palpitations with the prolapse. I mean, you get the feeling I'm trying to give you a pint. Now, if you're thinking about what else begins with P, right? Peanuts, pinochle, no. Life is a Rorschach test. Okay. Panic attacks. That's it. Pain, palpitations with prolapse, panic attack. And not once you know you have it. You can have anxiety disorder. Hi. You get the point? It's the opposite. This doesn't give you pain, palpitations, or panic attacks. It presents with shortness of breath. The causes are different. The presentations are completely different. The auscultation is opposite. The treatment is exactly opposite. And the last thing on our valve disorder routine here is why is it that the auscultation of mitral valve prolapse is the opposite of the others? And it has to do with the mitral valve leaflets. And here's the story. Here's a mitral valve annulus. Here is a mitral valve annulus. The mitral valve annulus is a fibroelastic ring on the inside of the heart. On the inside of the heart is this fibroelastic ring upon which the mitral valve leaflets are attached. When the heart gets bigger, the ring gets bigger. When the heart gets smaller, the ring gets smaller. When the ring gets bigger and smaller, do the leaflets change in size? Are you sure? Are you positive? That's true. As the heart gets bigger and smaller, the ring gets bigger and smaller, but the leaflets don't change in size. So where are these leaflets going to go? You see, if the leaflets don't change in size and the ring gets smaller, you got all this extra floppy leaflet. And where is it going to go? Well, they just don't fit together. The leaflets just get extra loose and floppy. They don't fit together, and they get more leaky because they're not fitting together. Now, when the heart gets bigger, the ring gets bigger, and it pulls the leaflets apart. And when the leaflets get pulled apart, they fit together better, and they don't leak as much because they're fitting together better. You see, it's called mitral valve prolapse because of the mitre, the bishop's hat, little split hat. These are the mitral valve leaflets. And as the leaflets get pushed together, they stop fitting if there's extra floppy leaflet. You see me? I see you. But as the heart gets bigger, it pulls them apart. And they fit together, and then they seal together better. And that's why a bigger heart with more blood has less murmur. They're fitting. Smaller heart, Valsalva, standing. Small heart, small ring. Small ring pushes the leaflets together, and they don't fit. That's why beta blockers work. Beta blockers make the heart bigger. Beta blockers pull the leaflets apart, and they fit together. And that's why the murmur is different. Because although it's mitral regurgitation, you get this mid-systolic click. Then you get this click, and then the murmur happens. Then the murmur happens. Trust me. Don't worry about it. Now the click is like having, I'm wearing the wrong shirt for this. Hello, how are you? Pretty good. Hi, good to hear. Good to hear. Okay, good. Extroverts of the world unite. Okay. So the point is that this is the mitral valve. These are the leaflets. They're extra loose and floppy because he's got a shirt that's just about one size too large. Now when the valve leaflets flop back into the atrium, when they flop back into the atrium, they stop short. And you go, yeah. People are like, like on rounds. Hear the S3? Yeah, You hear the murmur? Yeah, I hear it. So when the leaflet stops short, it makes a noise. Like, that's the click. Okay? Like this. Ready? Click. And it's not just because of the pen. Much? Okay. All right. Pretty good. Okay. Get a free interview for that. But you get the idea? You can relate to it if you think of it, if you could think of the leaflets like clothing. Your underwear or a shirt that's large, right? And it just stops short, and that's the click. And you can see that if the shirt was tight and you made the valve pull the leaflets apart, there'd be no excursion. You pull on it, but it'd be like, no, it's pulled tight. There'd be nothing no distance for it to move. So there's no click. And that's the whole essence of it. Beta blockers make the heart bigger, and it doesn't regurgitate. Okay? Now, anything that we wanted to say about dilated cardiomyopathy, we said 2 hours ago with the congestive heart failure, with the lady who was the 67-year-old lady with the pizza and potato chip diet. Anything that we wanted to say about hypertrophic cardiomyopathy is right here. The obstructive symptoms, shortness of breath, syncope, rarely sudden death. Treatment, beta blockers. Occasionally, you got to go cut that piece of meat out. You got to mechanically remove the obstruction. Do a muscle-ectomy. Get this muscle off of me. And mitral valve prolapse, beta blockers for the reason we just said. So this is hypertrophic cardiomyopathy. The other one was the dilated cardiomyopathy. Now, the only thing about restrictive is not that much to say. In the cardiomyopathy section, we've already done dilated, you've already done hypertrophic. And restrictive cardiomyopathy combines all of the most exciting aspects. Restrictive cardiomyopathy combines the most exciting aspects of a dilated cardiomyopathy that doesn't contract and a hypertrophic cardiomyopathy that doesn't relax. flip, 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 flip. Look at them now. The notes won't change. Well, they'll change later. Okay? Okay, we're going right in order. We're going right in order. Okay. So the things that are restrictive cardiomyopathy, they don't contract, they don't restrict, and it's just important just to know simply those things are the few most common of the things causing restrictive cardiomyopathy, just as a matter of distinction of what type of cardiomyopathy it is. In other words, we don't use beta blockers on them because they're not hypertrophic. We don't use ACE inhibitors and diuretics because they're not dilated. What causes a restrictive cardiomyopathy? Don't look down. What causes a restrictive? Like what? Connective tissue diseases. Amyloidosis, which is not really connective tissue disease. That's sort of protein boogers that accumulate from any chronic inflammatory disease. Okay, protein booger disease, also known as amyloid. What else? Myocarditis. No, that causes a dilated cardiomyopathy. Viral myocarditis. What? Some. I can't hear you. Carcinoid. Oh, carcinoid and cancer. Cancer in general, carcinoid. That's not so much that's a kind of a myocardial fibrosis. There's cancer, and there's also fibrosis from carcinoid. Carcinoid causes fibrosis. So fibrosis, yes. Amyloid, cancer, and fibrosis. What else for restrictive? Sarcoid, amyloid, hemochromatosis, sarcoid, amyloid, hemochromatosis, cancer and fibrosis, sarcoid, amyloid, hemochromatosis, cancer and fibrosis, sarcoid, amyloid, hemochromatosis, edit it and I'll kill you, sarcoid, amyloid, hemochromatosis, cancer and fibrosis. That's what causes restrictive cardiomyopathy. What causes restrictive cardiomyopathy? No, from the top. 1, 2, 3. 1, 2, 3. Fibrosis. Now listen. You'll be thinking this stuff and you say, this man is an idiot. Now first of all, that's Dr. Idiot to you. Second of all, I'm not perfect, but I'm perfect for you, as they say. Now, you'll think this way, but when test day comes and they're asking you question 123 on restrictive cardiomyopathy, and you'll see yourself in test day. Restrictive cardiomyopathy. Sarcoid, amyloid, hemochromatosis, cancer and fibrosis. Yes, this can't be useful. It's like fun. By the way, if it's useful, it should feel slow. It should feel like it's coming slowly because the sense of time will alter. So the time seems to fill up with more big spaces and gaps. Same amount of information. Okay. Now here's pericardial disease. Pericarditis. Don't turn that page. This is like this. I got to get this described in DSM-5, whatever this sort of little note fetish you've got. What infections? TB cause pericarditis. What other infections? Viral. Everybody just likes going around saying Coxsackie, Coxsackie, yes. Viral, okay, pericarditis. TB, virus. What else? Rheumatic fever is not an infection, it's an inflammatory problem. What other infection? Come on, come on. Uremia is not an infection the last time I checked. Oh my God. What infection causes, I know, causes, it's the name of a disease. It's the name of a disease. Okay. Commander of the public good over there. All right. So what other infection? TB, virus. Come on. Don't look at it. Parvovirus is not a cause of pericarditis. Those not okay. Infection. SLE is not an infection. What infection causes besides viral? Staph aureus can. You think you don't know, don't you? You think you don't know. You see, this is it. You think you don't know, but you do know. That's the problem. You're under the illusion that you don't know. Greater heroes and bards sleep within you. They refuse to awake at the touch of any man's hand but mine, so says Walt Whitman. Greater heroes and bards sleep within you. You know the answers, but you don't think you know it. This is a painful thing. Can Streptococcus do it? Can Streptococcus? Yes. TB, viral, strep, staph, Klebsiella, Pseudomonas, TB, rickettsia, syphilis, cytomegalovirus, toxoplasmosis, rickettsia, toxo, staph, strep, anaerobes, gram-negatives. What'd you say? Everything or anything? What infection? Oh, you think you don't know. But you do know. You think I'm being cruel and intrusive and invasive by not allowing you to read your notes and read this right now. You think I'm hurting you. You know what I mean? He's so pushy. Well, I am pushy. You'll have to forgive me. Okay? I'd be easy to love if I was perfect. But do you really want to go look at that list of 12 or 14 organisms and sit around tonight and memorize them? You really want to do that? It's painful. Also, it hasn't changed in the last 150 years, has it? I mean, TB, virus, staph, strep, anaerobes, gram-negatives, rickettsia, CMV, toxoplasmosis, syphilis, Lyme disease. It hasn't changed, except we didn't know there was Lyme 100 years ago. But you got to look at it right this second? No. Anything. Anything. And viral is the most common. Well, you can do it your way. Memorize. Like an intellectual enema. Well, inflammatory disorders and connective tissue disorders that people had said, things like lupus and uremia, scleroderma, what other inflammatory or connective tissue disorders can cause lupus? What else can cause lupus? What else can cause? What other inflammatory and connective tissue disorders? Which are them? Procainamide causing a lupus-like pericarditis? Absolutely. Hydralazine causing a lupus-like pericarditis? Absolutely. What other inflammatory or autoimmune problems can do it? Connective tissue. Rheumatic fever? Yes. And rheumatoid arthritis, right? As a connective tissue disorder can do it, right? Keep writing. Oh, keep writing. There we go. What else? Think good. Lupus? Rheumatoid arthritis? Scleroderma? Sjogren's syndrome? Mixed connective tissue disorder? Uremia? What'd you say? Anything or everything? What connective tissue disorder can't cause pericarditis? Cannot. No. They all can. They all cause pericarditis. Which one can't? You've been misled. You've been told to memorize. You've been misled. Memorization is not necessary anymore. Any inflammatory or connective tissue disorder can cause pericarditis. You've been misled. You've been told. But now we're all going to be obsolete because anybody with a Palm Pilot can click on pericarditis and scroll down the list in 2 seconds flat. Inflammatory connective tissue disorders, any inflammatory, Dressler syndrome, inflammation post-MI, trauma. Which types of trauma cause pericarditis? Open heart post-pericardiotomy syndrome and open heart pericardiotomy trauma, the surgeon's knife, yes? Chest wall trauma, that's right. Trying to eat a steering wheel through your chest in the car, that's right. Okay, absolutely. Chest wall trauma from that post-pericardiotomy. What other kind of trauma? What? Oh, blunt trauma. What other kind? penetrating trauma, blunt trauma. Keep going. What else? Keep writing. Keep writing. Blunt trauma, penetrating trauma. What? Emotional trauma? I was at a presentation for the cardiology fellows a couple of months ago, and a senior cardiology fellow, a guy about 12 minutes away from becoming an attending, is presenting on pericarditis. He throws up the list of things that cause pericarditis. He says, okay, here are the things that cause pericarditis, and there's all the students and the residents, the fellows in there, and he goes, these are things that cause pericarditis. You got to know all these. Staph, strep, anaerobes, gram-negatives, Lyme disease, uremia, post-pericardiotomy, lupus, scleroderma, Sjogren's syndrome, rheumatoid arthritis, rheumatic fever, blunt trauma, penetrating trauma, post-pericardiotomy, Dressler syndrome, and everybody in the audience was like this, like the old Maxell tape ads, the guys in front of the speaker, and everybody's like this. So the end result is, what did everybody learn? Nothing. The attendings who knew it, and the attendings went, oh, very nice, very complete, very wonderful. And all the students and the interns in the residence room were like this. You want to get a beer? Because to try to learn like that is too much. It's too much. But there happen to be over 50 separate causes. Now you go in a big textbook tonight. When you're done, either this class or watching this tape out there in Videoland, you go look at a major textbook. And you go see any major textbook, the list of stuff. And I defy you to find a way that says that it won't fit into one of these things. Because it will fit into one of these things. And it's much easier than memorizing. But you can't do it just for pericarditis. You're going to have to do it for every kind of disease. Now we get to cancer. What? Cancer, what? What? Cancer, what? I bet you think you're so smarty pants now. You do me smarty pants. I bet you think you know. What kind of cancer causes pericarditis? No! Not anything. Not anything. Can penile cancer cause pericarditis? Can it?
No.
It depends on what's near your heart. I was once watching a guy learn pericarditis. He was going like this in a room. I hear him going like this. Lung, breast, lymphoma, esophagus. Lung, breast, lymphoma, esophagus. I'm Henry, what are you doing? What are you doing? What are you doing? I goes, oh, hey, Conrad, I'm taking my boards next week, internal medicine boards. And I'm learning all the things that cause cancer, that cause pericarditis. But it just won't go in. It just won't go in. It just won't go in. I go, well, Henry, maybe it's already in. Maybe it's like a videotape player at home. You can't get a tape in it. You know, go home, can't get a tape in, can't get a tape in. You know, it's a guy kind of thing. I can't get this tape in. Well, honey, maybe there's already a tape in. Like home, huh? Maybe you're in it. So I go, Henry, what organs are anatomically near the heart? He goes, well, lungs are near the heart, the breasts are near the heart, the mediastinal lymph nodes, and the esophagus is anatomically near the heart. Okay. Henry, what kinds of cancer cause pericarditis? I don't know. You get pain that is positional and pleuritic. You get pain that is positional and pleuritic. The EKG shows ST segment elevation everywhere. ST segment elevation everywhere. The EKG shows ST segment elevation everywhere, and that will get you the 80, the 195 that you're looking for. But what if you want to go into radiology and you're looking for your 248? What do you see that's very, very specific for pericarditis on an EKG? Low voltage? No, that's tamponade. Tamponade gives low voltage. Smoothing of the ST segment is the ST segment everywhere, and the spooning is just pericarditis. That's pericarditis, but I just said that. The ST segment elevation everywhere. Something even more specific, pathognomonic. Nothing else causes it except pericarditis on an EKG, and it is? What does this mean? Notch of what? ST segment. No. T waves. Keep going. T wave. QRS. PR segment depression. PR segment. Just because you've not heard of it does not make it wrong. PR segment depression. Look, if you're looking for, 2 points past passing, don't learn it. But, some people are taking this for passing, and some people take it for augmentation. PR segment depression. Okay? Pain that is positional and pleuritic. And you treat it with non-steroidals. You correct the underlying etiology, but the ones that don't have an identified etiology are mostly viral, and that's non-steroidals. And if the non-steroidals don't work, then you use prednisone. Non-steroidals first, and if the non-steroidals don't work, then you use steroids. If you can't work with the non-steroid, then you use the steroid. Pain that is positional and pleuritic. Now, that is a functional problem, inflammation. It has a functional presentation, pain that's pleuritic and positional. It has a functional test, the electrical function of the heart, and a functional treatment, anti-inflammatory function. Whereas cardiac tamponade is a hemodynamic disease, it has a hemodynamic presentation, and it has a hemodynamic test and a hemodynamic treatment. What causes pericardial tamponade? Trauma, myocardial contusion. Yes. What else causes tamponade? Rupture of the heart. Yes. What else? Uremia. Watch this. Shh, shh, shh. I know you want to be like, I got the picture, okay, I got the idea. Don't look into his eyes, shield your eyes, I understand. I got it, it's okay. Okay. What causes tamponade? Infection. What infection? You don't know? You see, here's the issue. You think you don't know? You look at the faces, and you look at your faces, and you out there doing video land, you think you don't know what causes pericardial tamponade, but you do. You just don't think you don't. What causes tamponade? Think you don't know. Staph, strep, anaerobes, gram-negatives, trauma, tumors, cancers, uremia, lupus. Oh. So you see, on one gyrus, but on another gyrus, you don't think you know, because it's not crossing your corpus cavernosum. You see? What causes tamponade? I don't know. I have no idea. I don't know. I have no idea. What could it be? I don't know. Let's learn it again. I could try and learn it again, but you know what? If I tried to give it to you all again, it just wouldn't go in. It wouldn't go in. Well, maybe it's already in, honey. It is. All of these things. Watch this. Pleuritis, pleural effusion, pneumonia. Pneumonia, pleural effusion. Pneumonia and pleural effusion. What infection can cause pneumonia? What infection can cause pneumonia? Pneumococcus, more Klebsiella, more Axella, E. coli. Can viruses cause pneumonia? Yes. Can staph cause pneumonia? Mycoplasma can cause pneumonia. Have we done enough yet? What infection can cause pneumonia? Anything. Just pneumococcus is the most common. Now, which of the connective tissue disorders have pulmonary involvement? What? Does lupus have pulmonary involvement? Yes. Serositis. Does rheumatoid arthritis have pulmonary involvement? Rheumatoid nodules, low glucose in the pleural effusion. Any connective tissue disorder can cause pleuritis and a pleural effusion. What cancer can affect the lung? The ones that are anatomically near the lung. Can trauma cause a pleural effusion? And trauma can cause you to have pulmonary contusion, atelectasis, which then causes pneumonia. Oh my God. Oh my God. You mean it's all the same things all over again? Any infection, any inflammatory disorder, generally speaking, trauma and cancers, you see it's the same idea. Pericarditis, pneumonia. What infection can cause peritonitis? Lupus, uremia, serositis, cancer, trauma. Oh my God, you mean you should get told to learn the same thing 5 times over? Yes, it's the same principle. Inflammation or infection, sometimes extravasating fluid, sometimes that extravasated fluid becomes chronic, and when it becomes chronic, that's called constrictive pericarditis. That's called constrictive pericarditis. If it becomes chronic, anything that becomes chronic can cause fibrosis and inflammation and calcification, causing chronic pericardial fibrosis. It's the same things. Don't memorize another set of diseases. Say which of these could be chronic. Uremia can be chronic. Cancer can be chronic. TB can be chronic. Viruses are very seldom chronic. It's any chronic inflammation, infection, trauma, or cancer. Anything that's chronic to allow you to have time to have fibrosis. Now, tamponade is a hemodynamic presentation. You get jugular venous distension, tachycardia, and hypotension. But that could be pulmonary edema. How will you distinguish that from pulmonary edema? Pulsus paradoxus and clear lungs. Remember the old clear lung thing? From the Paleozoic of 4 hours ago? I know it seems like we've been together forever. But it's only been a few hours. Clear lungs and a pulsus paradoxus. Pulsus paradoxus. It's a hemodynamic disease with a hemodynamic presentation, with a hemodynamic test, the echocardiogram, and a hemodynamic treatment. I do a needle for a pericardiocentesis, and I tap out fluid, and what ends up happening is I relieve the pressure on my heart, my right ventricle pops open, my blood pressure comes up, and you save my life. The problem is that after the pericardiocentesis, that the fluid reaccumulates and it compresses again. So you needle it again, and you remove the fluid, and it comes back to life, but then the fluid reaccumulates again. So what do you have to do to treat it now? Sclerose. That's a good idea. That would go for pleural diseases, where you do pleurodesis and sclerose it and put in talcum and bleomycin, but you don't do that for the pericardium. Chronic pericardial effusions. You don't want to keep putting a needle in every 5 minutes. Shunt. Ooh, that's good. To where? Huh? Peritoneal. Now, that's a good idea, though. I never thought about that. You don't have to. Not necessary. You got something easier. No. Because you don't want to put a hole through the myocardium. Because blood would shoot out of the pericardium, out of the heart and into the pericardium if you put a hole in the heart. If you put a hole in the heart, fluid's not going to go back in. Blood's going to come out. Keep going. Vena cava. No. Another one. No. Shunt. No. Whoosh, whoosh, whoosh. Back into the heart. No. Whoosh. Lower flow. Lower pressure system around there. A window. Pericardial window. Hello? It's a hole around the heart, man. You cut a window, a hole, into the pericardium. But they don't like to call it a hole. It's a hole in the pericardium, and the fluid would just drip out into the pleural space. So a pericardial window, a hole into the pericardium, and just the fluid comes out. Because if you put a hole in the pericardium, it'll go from the higher pressure system in here to the lower pressure system in the pleural space. And therefore, it'll just get reabsorbed into the pleural space. If you put a hole in the heart, blood will squirt out. That'll be bad. So it's just a hole in the heart. Well, we don't like to call it a hole for poetic reasons. No, it's true, right? Doctor, what are you going to do to my husband? I'm going to pull out a hole into his heart. Oh. Hole in the heart. Doctor, what are you going to do to my husband's heart? I'm going to put a window into his heart. A window into his heart. That's so sweet. I'll be able to look in anytime I want. That's nice. Now you know why. It's a hole. Okay? So, constrictive pericarditis is an anatomic disease. You anatomically can't fill up the heart. The heart starts to fill, but the heart hits this fibrotic calcific box. And it hits this fibrotic calcific box, and the blood backs up. It backs up into the neck veins, and you get JVD. It backs up into the abdomen, and you get ascites. It backs up into the abdomen, and you get a big liver. The heart starts to fill, but it can't fill because it hits this fibrotic box around it. It's a calcified fibrotic box around the heart, and it can't fill. So it backs up neck veins, liver, ascites, edema. But that is just what you'd find with congestive failure and clear lungs here. That's true. But what does that constrictive pericarditis give you that congestive failure does not? There's something it gives you. The heart is filling, but it hits this box. And it's filling, and it hits this box. And what are you getting in constrictive that you don't get with the congestive failure? A what? Hypertension? No. A what? Pulses? No. Shortness of breath? No. Rub? Not exactly a rub, no. Not a rub. A what? A knock? I'm rubbing my fingers raw doing this. I do it for half an hour. You get a what? A rub, no. You get a shortness of breath? No. Knock. Knock. So you do an anatomic test called a chest X-ray or a CT, and you have to, I would throw this, but that's probably not. Okay. That's why I do that. So. And you have to simply remove the pericardium because it's an anatomic problem. Anatomic tests to look for calcium and fibrosis. An anatomic removal of the pericardium. All the same diseases cause all of these based on whether they're acute, they extravasate fluid, or whether they make fibrosis. Hemodynamic cure, anatomic cure. arrhythmia management is best thought of in terms of what do I need to study? I need to study those things that would be expected of me during my internship. Now, that seems straightforward. Now, the greatest thing I can do for you is tell you what not to study. Don't study anything complex. You don't say, well, I need to worry about whether it's radio frequency catheter ablation for this particular arrhythmia, or an implantable defibrillator, or some sort of cryotherapy to ablate this arrhythmic tract. The kind of arrhythmia management you need to know is the first hour of management. The kind of arrhythmia management you need to know is, hi, I'm the attending physician. You are the intern in the hospital. Keep my patient alive for the next 2 hours, for the time it takes me to get in from my palatial home in Malibu. Therefore, let's start with this. You have a 47-year-old man who comes to the office seeking advice about diarrhea prophylaxis prior to going on a little vacation to Thailand. He just wants to know about what sort of diarrhea prophylaxis to take. And you notice that he feels okay. It's just that he has a pulse, heart rate. Somebody got me on that one before. Well, pulse is not the same as heart rate. So a heart rate of 47. He's 47. He has a heart rate of 47. Maybe tomorrow, next year, his heart rate will be 48. He has a heart rate of 47. What is the next best step in the management of this patient? EKG or atropine? Or transcutaneous pacer? More history. What kind of history? What kind of more? No, he's not taking any medications. No prior MIs. He's just a guy who wants to go to Thailand as quickly as possible. No symptoms. No shortness of breath. Huh? And ultimately you say, this is the information you get. You can't go that way on the test, on test day. Go, excuse me, Proctor, come here. Listen, this question, I can't answer it like this. I need some more history on this one. I just won't work under these conditions. I need to know some more about past medical history. No, I've given you everything you're going to get at the moment. So the answer is not atropine and not a pacer, because he has no symptoms. If he had symptoms, if he had hypotension, if he was confused or lightheaded, then you would use atropine. And the first thing to say, are there symptoms? Are there symptoms? And the answer is here, if there was symptoms, then it would be atropine acutely to speed up the heart rate, and then a pacemaker later on. Any kind, atropine and pacer for bradycardia. Any kind of bradycardia that's symptomatic, you use atropine and pacer. Now, if there's no symptoms, the answer EKG was the correct answer. Because if it's sinus bradycardia, first degree AV block, second degree AV block, third degree AV block if it's Mobitz 1 or Mobitz 2. If it's sinus bradycardia at a rate of 47 in an asymptomatic guy, what do you do for a sinus bradycardia at a rate of 47 in an asymptomatic guy? What do you do? Leave him alone. That's right. There's no therapy for that. There's no therapy for that. Normal pulse rate is 60 to 100. But that normal pulse rate of 60 to 100 is just a societal average. Why is 174 a passing grade on step 2? Because that's what we've decided normal is. Above that, you're normal. Below that, you're a part of the damned. Is 173 any different from 174? Is 176 any different from 173? Probably not. Well, you had to draw the cutoff somewhere. And the same as it is with heart rates. Some people are smart and knowledgeable, and they just have less than 174. The same way some people are below 60, and they have no symptoms. That normal heart rate of 60 to 100 is based on thousands of military recruits between the ages of 18 and 24, 2 hours postprandial in the supine position. And if you're thousands of military recruits, 18 to 24, 2 hours after you eat, male, lying flat, that's a normal pulse. But some people are going to be normal and they're just below that. What if his heart rate was 37? What would you do for him then? If his heart rate was 37, what would be the next best step in the management of this patient? If his heart rate was 37. Does he have symptoms? No, he has no symptoms. EKG, that's how come you knew it was sinus at 37. What if it's sinus at 37? What would you do for that? Nothing. But what if the heart rate was 3? A year. What if he's a vampire? What? You know, Buffy the vampire. You know what I mean? He's in Buffy the Vampire Slayer here, and here he is with a heart rate of 3 a year, and he's feeling great, and he's feeling fine, and he's doing merengue, and he's having a good time, and he feels no symptoms. I don't care how low it is. You don't do anything. You don't do anything because he's got no symptoms. And what do you do about first-degree AV block? Nothing. You don't care about first-degree AV block because first-degree AV block doesn't go on to anything. First-degree AV block doesn't become second-degree. First-degree AV block doesn't progress. It's not evil. And the divided line is here. Mobitz 1 is the Wenckebach. Mobitz 2 is worse. Mobitz 1 is part of the normal aging of the conduction system. Mobitz 2 is associated with ischemia. Mobitz 1 doesn't go on to third-degree AV block. Mobitz 2 does go on to third-degree AV block. Mobitz 1 is not a problem. Mobitz 2 is evil, and it can become worse. So Mobitz 2, even without symptoms, you'd put in a pacer, and the same with third-degree AV block. We don't wait for someone to have their first syncopal episode while they're driving down the opposite lane of traffic from us. To have their syncopal episode and fall pass out at the wheel while they're driving near us. And you put in a pacemaker anyway to prevent the syncope. Mobitz 1 doesn't go anywhere. Mobitz 2 does. And that's how you determine all the bradycardias. Now, you have a 28-year-old female Brazilian medical student who has been preparing for USMLE Step 1. So she's having all of the 4 basic food groups: alcohol, nicotine, caffeine, and chocolate. 4 basic food groups for doctors. And she comes in and she says, I've got palpitations. My heart is fluttering. And she comes to you and says, my heart is fluttering and I have palpitations. And she's got, of course, an EKG, and she has supraventricular tachycardia at a rate of 160. Now, we can go over this management of the SVT and say, give adenosine here and vagal maneuvers here and shock here and beta blockers, calcium blockers, digoxin. And then do AFib and say, we use vagal maneuvers here and beta blockers here and digoxin here, calcium blockers here, shocking here. And then do atrial flutter. We use beta blockers here and digoxin here and shocking here and vagal maneuvers here, and say the whole same thing over and over and over again like it does in any textbook, like it does in your notes. Or you say, why say the same damn thing 3 times? Put multifocal atrial tachycardia, atrial fibrillation, atrial flutter. All the same, All the same. They're all the same in their management except for one thing. There's only one point of difference between them. There's only one difference in the management between these, which is anticoagulation. Almost, sort of, semi-anticoagulation. New onset, old onset. That's the anticoagulation. New onset, old onset. This arrhythmia is too fast. This arrhythmia is too slow. This arrhythmia is just right. Adenosine. Yeah, that's true. Adenosine is usually reserved for those things that you know that you've just forgotten. So, well, I guess. So adenosine is the only point of management that's different between these. If she has palpitations, an SVT, MAT, AFib, A-flutter, multifocal atrial tachycardia at a rate of 160, what's the first thing to do? Don't say an EKG. How do you know there's SVT unless you had an EKG? You had an EKG, and that's how you know it's SVT or AFib or A-flutter. What's first? Step. Next. Cardiovert. Do we shock her? The answer is? Is she unstable? Is she unstable? Well, because that's the point. If she's unstable, in fact, you will shock her. You will shock her if she's unstable. You will shock her if she's unstable. So we better all have the same definition of unstable. Can you imagine this? People come in to the hospital and they have AFib or A-flutter or SVT or multifocal atrial tachycardia. And one of you says, I give her digoxin. The other one says, I give her beta blocks. The other one says, not at all. I burn all the hair off her chest and do electrolysis and shock her. Well, we better all have, and you say, well, I'd shock her if she's unstable. Well, what do you mean by unstable? Well, I mean maxed out on her credit cards? I don't know. What do you... We better all have the same definition. What does it mean to be unstable? Hypotension, which is blood pressure. Okay. Hypotension on blood pressure. All right, I'm up with that. I'm with that. Sure, I'm with you. Okay. Blood pressure, hypotension, I'm with that. Sure. Hypotension. That would mean unstable. Sure. Blood pressure. That's straightforward. That's easy. We can all agree on that, right? We can? Sure. Systolic or diastolic? You say systolic, you say diastolic. Oh, we can all agree on that. Systolic, diastolic, I don't know. What do you mean by unstable? Let's go back to being maxed out on the credit cards. You see. We've got to have the same definition. Now, these things that I'm going to give you for hemodynamic instability are probably the single most important point of data you can get. If a patient is presented to you and that patient is hemodynamically unstable, that is the most important thing in the question. More important than anything else. More important than, is it GI bleeding? Is it cardiogenic shock? Is it sepsis, DKA, burns, bradycardia? Are they unstable? If somebody's in with depression and loneliness, if they're hemodynamically unstable, that's the most important thing. So we better all agree. Because you know how I said chest pain. Forget about everything except positional, pleuritic, or tender. That tells you cardiac, non-cardiac. Chest pain, EKG, ST elevation or not ST elevation. The pivot point, the decision point, is based on stable, unstable. We better have the same definition. So it is low blood pressure, but it means a low systolic. So we can all agree on that. I mean, that's straightforward, right? We can all agree on that. A low systolic blood pressure, sure, that's straightforward. That's easy. We all agree on that. Low systolic blood pressure. How low? 100? 90? 80? 70? How low is low? How low is low? I know. I don't like it when you have to call dropping your pen. I get near her and she drops her pen. She goes, oh, I lost, dropped my pen. How low is low? How low is low for you? Less than 60. That's low. I agree. His blood pressure is 70. Yeah, it's all right. It's not under 60. Let him go. It's only 70. So we better agree on a definition. It's a systolic blood pressure less than 90. Systolic blood pressure less than 90. Systolic less than 90. And you say, but I'm 5'0" on a hot day, and I only weigh 94 pounds, and my normal systolic blood pressure is 88. Does that mean I'm going to get shocked? It means yes. Stay away from an emergency room. You're going to get shocked. Systolic less than 90. Welcome to ACLS, Advanced Cardiac Life Support. Welcome to ACLS. Every intern in the country is going to take this. Everybody entering training in the United States has to take it because I'm not running those codes. Right now at Maimonides in New York, who at Maimonides back at my place is running the codes? It ain't the attendings. It's interns and second-year residents. It's you guys. So that means everybody's going to take it. If not for step 2, you'll take it eventually. Systolic less than 90, shock. What else is hemodynamically unstable? Think. Tachycardia, no. Not going to shock them just because their heart rate is fast. Lower your heart rate. Bang! Zzz. Oh, it's still fast. It's still fast. Bang! There! Lower your heart rate. Told you, lower your heart rate. Bang! Torture. No. Here's what'll help you. You have to think what shocking feels like. When would you let somebody do this to you? If you're at home tonight, what could you do at home that could simulate the full joys of being cardioverted? What can you do to simulate this at home for yourself? Touch a bare wire? No. Not of touching a bare wire. You could be home ironing with your feet in a bathtub. Ironing. And you take the iron and you go. I know. Because that's what it feels like. You put that jelly on the chest in order to increase the conduction of electricity into the heart. In addition, you put that jelly on the chest in order to decrease the burn. Because dry skin burns. So when would you let somebody put a hot iron on you? And you say, never. And you say, not never. You would let somebody do that to you if the alternative was some form of life-threatening, you gonna die thing. Like I got low blood pressure and I'm gonna die. Like I have chest pain, insufficient perfusion of my heart. I better fix it. I don't feel like having a myocardial infarction this evening. Would you like a myocardial infarction this evening? No, how about dinner and a movie? No, myocardial infarction, dinner and a movie. It's so hard to tell. I have such hypoperfusion that I'm having chest pain and I'm going to have a myocardial infarction. What else is like that? Kidney, urine output. Low urine output shocked him. Are you peeing right now? Then shock him. He's not peeing. Shock him. She said, I'm sorry, I'm going to have to shock you. Okay? She said low urine output. Now, from one point of view, you're right. From one point of view, you're right. Low urine output indicates hypoperfusion. Low urine output, insufficient perfusion of the kidneys, I'd like to shock that. That's true from one point of view. The problem is you can't tell now. You're not urinating now, are you? Good, I'm glad you checked. You checked. No, you're not. Therefore, you can't use low urine output because you can't tell now. How would you tell now? Well, it's true. You could intubate the penis. That's true. And put a catheter in there and see if putting a catheter in there, whether or not you had urine output now by putting a catheter in, but it still takes several hours. So you can't use that. It takes several hours. What can you use to tell now is shortness of breath. Shortness of breath. Meaning I can't breathe. Shortness of breath. I can't breathe, and I'm going to have a heart attack because I can't breathe. And the last thing is unconscious, altered mental status, confusion, disoriented, and I'm going to have a stroke. And then somebody always comes up and says, oh, yeah, but I have a question. Yes. People with Alzheimer's disease, they're confused. Do I have to shock that? Shock, shock, shock? No. Hemodynamically related confusion. hemodynamically related confusion, that's who you shock. If it's insufficient perfusion of the brain and you're going to have a stroke, you got to fix that, and you got to fix it now. So these things are your constant star. What do you see? I see hypotension, shortness of breath, chest pain, confusion. What else is in the case? I don't care. I see shortness of breath, hypotension, chest pain, and confusion. And then you shock. VTach, AFib, aflutter, SVT, multifocal atrial tachycardia, antiarrhythmia. It's the same thing. How you define it. Well, she's not unstable, she's stable. So what would you do next? Lidocaine is never for atrial arrhythmias. Lidocaine is for ventricular arrhythmias. Lidocaine is for hemodynamically stable VTach. Lidocaine ventricular, lidocaine ventricular, lidocaine ventricular, lidocaine ventricular. Vagal maneuvers. If someone is rapid and stable, if they're rapid and stable, then it's vagal maneuvers, carotid sinus massage, block down the AV node, Valsalva, now that we finally figured out what it means, block down the AV node, vagal maneuvers. What else do you do to increase vagal tone? Dunk their head in a bucket of ice. That's right. Put their head in a bucket of ice. Yes. What'd you say? Pressure fingers in their eyeballs? Ooh. Huh? Carotid massage, dive. What about rubbing their eyeballs? Carotid eyeball massage? So you're okay? Doc, I have palpitations. Really? No problem. Ah! Well, I guess your mind is off your palpitations, isn't it now? We're not worried about palpitations, isn't it? Like that movie Event Horizon, you know? Where we're going, we won't need eyes to see. Now listen. Vagal maneuvers by pressing on the eyeballs does slow down the heart rate. It does. And the eyeball pressure definitely does decrease the heart rate. Eyeball pressure does two things very successfully. It slows the heart rate and it blinds the patient. Don't do that. As in, Doc, it hurts when I do that. Don't do that. Now, I know some of you are like, but I was told, my teachers, my professors, and people with far more normal nervous systems than you told us that that's what you do. I know. I told you, think of this like group therapy. I know. But eyeball massage causes retinal detachment, and we don't have to. The United States, the American Heart Association, is far more sophisticated and civilized than that. We don't advocate pressing on the eyeballs. Check it in the ACLS book. No, it's far more sophisticated. It's instead of pressing on the eyeballs, you press on the Welcome to America. Circumferential digital rectal examination. Yeah, so change your whole attitude towards cardiac resuscitation. Look at over there, poor Alan over there. He's like, not till after I'm married. Circumferential digital rectal examination, vagal maneuvers, carotid sinus massage. Basically, it comes down to carotid sinus massage. You do carotid sinus massage and it doesn't work. What you do next is you would do... Yeah, I'm not making that one up. You got to look it up. The references. Value of circumferential digital rectal exam in management of atrial arrhythmias. Definitely, it's in there. Okay, have you running home to watch the books now, right? If it's SVT, you use adenosine. Hey, how do you expect to stay paying attention after 8 hours? You know what I mean? Adenosine for SVT, and only for SVT do you use adenosine. It's not effective for the others. It's only effective for SVT. Now, if these things don't work, then you have to slow the rate. You slow the rate. You could use digoxin. You could use a beta blocker. You can use a calcium blocker. How will you know which one to use? Because they all have the same indications. They all slow you, but not convert you. They all slow, but not convert you. They all slow the rate, but they don't convert the rhythm. So they all have basically the same effect. They're rate drugs, not rhythm drugs. They're rate, not rhythm. How will you know which one to choose? There'll have to be something in the case that tells you. Now, another way is, some of you are probably saying, well, I'd use DIG. Well, I'd use calcium. Well, I'd use a beta blocker. And if you're saying that you know, you're basically thinking based on what you saw your attendings use. There's no one as conservative as a medical student or a resident, because you only know what you've seen in your place. Maybe you saw a guy, he said digoxin for everybody. Maybe your guy said, no, calcium blockers. I'd use diltiazem. The answer is they all block down the AV node. It usually goes like this. If you went to medical school in the 70s, you used digoxin. The 80s, you used beta blockers. The 90s, you used calcium blockers. But it's not really any objective difference. They all slow the rate. They'd have to tell you something. They'd have to tell you something. For instance, what if we said she had a history of asthma? What would that mean? No beta blockers. No beta blockers. No, so we do this. A, B, C, D. No, well, then we'd use the calcium blocker. If they did that. Okay? They'd have to tell you something. It'd have to be tell you something. Now, I recently retook some internal medicine boards, 10-year expiration. And the interesting thing was, rapid AFib that was hemodynamically stable, what's the next best step in therapy? There it is, on cardiology subspecialty boards. Same damn question. I said it can't be. It's too easy. This is straight out of the Step 2 course. And 2 out of 5 cardiology friends I talked to got it wrong because they answered based on their own little idiosyncrasies. Oh, I've used beta blockers in asthma lots of times. And it's been okay. I haven't seen any bronchospasm. But no, they just wanted you to know, if you have 2 drugs that are okay, don't use the one that has a contraindication. But they're not going to give you questions that say, which of the following is a contraindication to the use of beta blockers? They're not going to do questions like that. It's going to be built into the case. So if they tell you to choose between these 3 things, I guarantee you there's something in the history that's telling you to choose one. Let's give you an example. 72-year-old former president of the United States of America is at a state dinner in Japan, gets up to make an important point, leans forward, and vomits all over the Japanese ambassador. He is found to have rapid atrial fibrillation. He is found to have rapid atrial fibrillation secondary to Graves' disease. And he has rapid atrial fibrillation. He has Graves' disease. His wife has Graves' disease. And who else had Graves' disease? The dog has Graves' disease too. Woo! What is the next best step in the management of this patient? What is the most appropriate action at this time? He has rapid AFib, secondary to Graves' disease. What is the most appropriate action at this time? If he's stable, it'll be beta blockers. Because beta blockers will block the effect of the sympathetic outflow from the hyperthyroidism. So therefore, it is the beta blockers. They'll have to tell you something. You know, there's an advantage of taking a board test. I know you don't think there's an advantage of taking a board test, but there is. In life, anything can be anything. But on the boards, they have to tell you something. And if you have 2 answers that look identical, it means they're telling you something in the history that you did not see. And that's how you make a choice. When will you answer Coumadin? When will you answer? When will you answer Coumadin? AFib. Insufficient data, Captain. No. Not enough. Not enough. AFib, not good enough. Not good enough. AFib when? What circumstances? What's going to be in that history that tells you? The what? The size of the atrium. Half credit, half credit. Duration. Ding, 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 ding. That's it. Duration. 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 Chronic AFib. Chronic. Chronic means how long for AFib. For instance, chronic hepatitis B is the presence of surface antigen beyond 6 months. That's for chronic hepatitis B. But how long is chronic for you for AFib? 2 weeks. Not exactly. 2 days. 2 days. For 2 days. Because after you have AFib for greater than 2 days, you become at risk of what? After you've had AFib for greater than 2 days, what happens to you? You become at risk of what? How's that? Emboli. You become at risk of emboli after you've had AFib for greater than 2 days. After 2 days, you put them on Coumadin because you become at risk of emboli when you've had it for greater than 2 days. Now you know why I don't say to you, AFib, use digoxin. AFib, use beta blockers. No, AFib, and what's the circumstance? The pivot point of circumstances in arrhythmias is unstable, stable. Unstable, stable. Unstable, rapid, shock. Stable, vagal maneuvers. That doesn't work. Adenosine is only for SVT. After that, you control the rate. Once you control the rate, you use Coumadin to prevent arrhythmias. You have a 57-year-old man. He is at the opera. He gets up in the middle of some Wagner 17-hour-long marathon, Germanic, kill me with opera, gets lightheaded and confused, and is found to have ventricular tachycardia. He has a blood pressure of 128/88. What is the next best step in the management of this patient? What is the most appropriate action at this time? Constipation. No. Not constipation. Shock or lidocaine? Don't bite your nails. Well, it's from the dim, dark past of 30 minutes ago. Does he have hemodynamic instability? Yes, no. Some of you say yes and some of you say no. That means some of you are right and some of you are wrong. But who is it? I. Well, the question comes down to, in VTAC, if it is stable, then you will lidocaine. And if it's unstable, then you will shock. So you better be sure, because I'd hate to have poor man's electrolysis and all the hairs burned off of my chest by getting my chest shocked when, we could have given him a little squirt of lidocaine. Yes, but this way he'll never have to go for a waxing again. So the point is, his blood pressure is normal. Is this person stable? No. No, he's lightheaded and confused. You shock. He's like this. Hey, ho, hey, oh. Yeah, but your blood pressure is normal, man. You're stable. Hey, ooh. Hey, shock. Chest pain, shortness of breath. Hemodynamically related confusion, hypotension. When you see those things, any one of them, you wouldn't say to him, hey, well, you only got chest pain. You're not short of breath. I'll let you just have an MI. Any one of those things. That's the VTAC answer. Let's have another 57-year-old man. Let's have another 57-year-old man again at the opera. 57-year-old man again at the opera. Gets up in the middle of the ring series, falls to the floor, and he's somewhat less than alert. As a matter of fact, he doesn't look so good, and he falls to the floor, and he's not getting up. Hey! What is the next best step in management of this patient? What is the most appropriate action at this time? You can't shock him, you don't know what it is. Yeah, see if he's responsive. Shock. Boom! A cattle prod school of medicine. Yeah! Zing! Where'd you go to school? World Wrestling Federation. No, you don't shock him. The guy's on the floor. What do you do next? ABCs. ABCs, ABCs, ABCs. I told you there's no answer that says ABCs. Are you Christine? There's no answer that says ABCs. There's no answer that says ABCs. It's not A, ABCs. B, DEFs. C, GHIs. You have to be very specific. Airway. So you intubate him. Ooh. 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 Hi, welcome in. Wham! Excuse me. Thank you. No. Conscious, unconscious. That is correct. Conscious, unconscious. First thing is to say, Annie, are you okay? Assess to see that he's really unresponsive. Listen, I've seen a lot of seemingly unresponsive people in the opera. I spent 2 years providing the physician coverage for the Metropolitan Opera House in New York, and believe me, 4 out of 5 people were just sleeping, okay? Annie, are you okay? Are you okay? I'm not okay. I'm dead. Before you go head tilting and jaw thrusting and chin lifting, what the hell? All right. I'm sleeping. Assess unresponsiveness. And you find out that he is, in fact, truly unresponsive. As a matter of fact, he is way unresponsive, extremely unresponsive, exquisitely unresponsive. What would you do next in the management of this patient? Intubate. We keep wanting to get to that intubate. Everything. Intubate. No? ECG. You don't have an ECG. Now, this is going to seem stupid to you. I know it's going to seem stupid to you. I know what you're going to want to do. You want to run forward and check a pulse. Look, I want to run forward and check a pulse. We all want to run forward and check a pulse. We all want to run forward and intubate. Believe me. But we can't. It's not my opinion. This will become clear why. First of all, unless you happen to have an endotracheal tube on you. Oh, yes, I have another one right here. Oh, whoa, what a trachea, pull a rabbit out of the hat. No, you gotta go. Yeah, good, you can read. Please cover your left eye and read the lowest line. Thank you very much. You gotta go, help, help, help. He's falling and he can't get up. Help, help. I'm serious, that's it. This is not this Conrad Fisher medical licensure exam. American Heart Association spent 30 years working this out. It'll become clear why. Help, help. All right, you know what? I changed my mind. We're going to do it your way. We're going to go straight to opening his airway. We open his airway. We look, listen, and feel. We do a couple of rescue breaths. And we start those compressions. Check the circulation. He's dead. And he's got no breathing, no respiration. You chart compressions. And let's do it your way. Ready? So you go straight to opening the airway. And you go and go. You go, ka-bunka, 3 or 4 or 5. 1 or 2 or 3 or 4 or 5. 1 or 2 or 3 or 4 or 5. 1, 2, 3, 4 or 5. 1, 2, 3, 4 or 5. Anything good on TV tonight? No, I don't know. Have they put the Emmy Awards on yet? No, I think they're going to be canceled. What do you think? Yeah. Yeah. Have you seen? Yeah. How long you got that for? How long you do that for? Till you get tired. That's it. But you see, what if you don't call for help? The point is this. How long do you have to fix this guy? How long before survival goes from 90% to dead? Like in The Princess Bride, right? It goes, right now he's just mostly dead. He's just mostly dead. How long because now he's all the way dead? How long between mostly dead and all the way dead? And what happened? What can you do for him when he's all the way dead? Go through his pockets looking for loose change. How long do you have? Follow the point. Follow. There's a reason behind this. Because, look, I have no doubt that if I just tell you guys like this, The first thing when someone loses consciousness or becomes lightheaded and falls to the floor is assess their unresponsiveness, call their name, and say, "Are you okay?" This is immediately followed by a call for help, dialing 911. Then you proceed to open the airway by the jaw thrust, the head tilt, and the chin lift. You follow this by checking a pulse, giving some rescue breaths, and performing the rescue breaths at a 5-to-1 ratio with 2 rescuer or 15-to-2 with 1 rescuer. I have no doubt that if I do that, you'll very dutifully go this, and none of it will stick to you. It won't stick because it's just facts. It's another intellectual enema. Which means you can retain it for a little while, but not permanently. How long? 10 minutes. You have 10 minutes to fix him. You have 10 minutes, like a straighter line. There we go. You have 10 minutes to fix this guy. You know what that means? 10% per minute. Ooh. Oh, now we got a whole new seriousness, don't we? 10% per minute die, and they're all the way dead. So you better be sure about the next step. And that means if you go straight to opening his airways and straight to those ABCs and do kapunk, 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 3 or 4, 5, and about 4 or 5 minutes later you go, you know, he's not waking up. We better call for help. After about 4 or 5 minutes, okay, we called for help. Up! I'm here. Oops. Too late. Now do you see why this is here? Because you better start calling for help and get all your toys now so that you have some chance of fixing this guy. Because if you start to do just chest compressions and you don't have the endotracheal tube, the EKG, the defibrillator, you're not going to be able to fix him because chest compressions don't restart the heart. They keep you alive while waiting to get the other equipment, the epinephrine, the atropine, the defibrillator. That will restart the heart. You find that he is pulseless. He is pulseless. What has he got? Kapunka, punka, punka. What's he got? What causes? What is the differential of death? VFib. Pulseless VTAC, which is shocked. VTAC, that's unstable, shocked. And people say, well, pulseless, isn't that very stable? He's dead, that's sort of very stable. Yes, it's sort of very stable or very unstable, depending on how you think of it. So he's dead, yes, but it's unstable, shock. So, VTAC, pulseless VTAC. VFib, pulseless. Asystole. Asystole is pulseless. And the artist formerly known as EMD, electrical mechanical dissociation, now known as pulseless electrical activity. Asystole. VFib. VTAC. Oh, well, you better have the equipment, because unless you have the equipment, there's only one way to tell these apart. What's the only way to distinguish these? EKG. Because they all look dead to me. So, you assess that he's unresponsive. Annie, are you okay? I'm not okay, I'm dead. Help! 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 Now you open the airway, start to breathe in, compressions, and you get all the help you can get. Okay? And you find out that he is in ventricular fibrillation. And you find out that he has VFib, and he's got no respirations, no breathing, no air movement, no breathing, no respiration, no air movement, no breathing, no respirations. And what do you do next if there's no breathing, no air movement, no respirations, and you have VFib? The next best step in the management of this patient is? I know, you want to intubate, don't you?
Well, breathing is the first thing you got to do.
Breathing is the first thing. I know, you want to intubate. I know you want to intubate. So say, I want to intubate. Say, I want to intubate. Please, I want to intubate. Say it, I want to intubate. I know you want to intubate. Ay, entiendo todo. Ay, I understand. How long does it take you to intubate? How long does it take to intubate? 10 seconds? 10 seconds. 10 seconds if you're in the operating room and they're paralyzed with succinylcholine, laid out flat like this with the laryngoscope and the tube like this, and then it's 10 seconds if you don't get it in the esophagus or knock their teeth down their throat. 10 seconds. Yeah, excuse me. Thank you. No, not 10 seconds. It takes some time in the field, positioning them around, suction them out, get the laryngoscope, put that tube in, 10 seconds. Come on. Let's say 3 or 4 minutes. That would be fast. All right, you know what? 3 or 4, did I say seconds? 3 or 4 minutes. All right, we'll intubate. We'll do it your way. We'll intubate. We'll intubate. 3 or 4 minutes, 3 or 4 minutes, 3 or 4 minutes. Yeah, it's all right. Yeah, all right. Yep. 4 minutes. Got it. No problem. Yeah, it's all right. We got the tube in. Okay, what happened? Well, we killed 40% of our patients. Got the point? Got the point? The point is, even if it takes you only 3 minutes to intubate, after you intubate VFib, what are you going to do next? What will you do next after you intubate? Defibrillation or shock? Well, I know it's the same thing, but you said it's different. Shock. Oh. Now do you see why you can't just go with ABCs? Look, if I could let you do that, I would. If I could let you go around and answer every question, ABCs, 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 I'd let you do that. But even if you intubate, you still have to shock later on. This will help you to understand. Shock. Shock, shock. Then you finally get to intubate and epinephrine and shock him again. Oh, it still didn't work? Lidocaine and shock him again. How long do you wait in between each of these shocks? Shock, bang! How long do you wait? Huh? You don't wait. You don't wait. Because if it's you, and I say, listen, every minute, 10% chance of death, you would move very fast. If I told you there's a 10% chance of you being dead every 10 minutes if you didn't get an action done, you would move mighty fast. You'd be like this, bang, 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 shock, done. Shock, shock, shock. How long in between the drug and the shock? No time. Shock. Give him the drug. Shock, 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 shock. Drug shock, drug shock, drug shock, as fast as you can. When are you going to answer intracardiac medications? When are you going to do that? Intracardiac. Take the needle and shoot the drug to the epinephrine straight into the heart. When are you going to do that? What? If it's Pulp Fiction and you're John Travolta in Pulp Fiction? On Uma Thurman? Yes, that's right. No, it's John Travolta in Pulp Fiction. Yes, that's about the only time. With the exception, the intracardiac. The answer for intracardiac is never. Never necessary. Never necessary. No greater efficacy, doesn't help, don't answer it. When are you going to answer thoracotomy? Thoracotomy. When are you going to say, oh, arrhythmia management? I gave shock, shock, shock. Squirt in the epinephrine, shock. Gave him the lidocaine, shock. Let's cut open the chest. Zip. Open there, going, when are you going to do that? Thoracotomy and direct massage. You can do that. What? When daddy needs a procedure for the procedure book. That's about it. The answer is that if you've gone and you've done shock, 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 epi shock, lidocaine shock, beryllium shock, and they're still dead, you're out over here. And trying to cut through their chest to go massage the heart won't help. So the answer for thoracotomy is never. When will you answer magnesium? Magnesium is an antiarrhythmic. Magnesium is pretty helpful. Magnesium's a mighty good drug to me. When are you going to answer that? Magnesium is good as an antiarrhythmic. Magnesium goes, calmate, to the muscles, right? Good for that ventricle. Calms down muscles. Good, right? For arrhythmias. Good for uterine arrhythmias, right? Like in premature labor. Right? As a tocolytic. That's a uterine antiarrhythmic, right? Magnesium. It's only good in one circumstance. I mean, it's good for a couple things, but you'll only answer it in one thing, which is torsade. Torsade de pointes. It's ventricular tachycardia that looks like it's twisting around a point. And it's always sexier to say it in French, I suppose, which is, you could say twist around a point, but it's not as good as saying torsade de pointes. That's the main thing in torsade. That's how fast you go. And no matter how much they say, no breathing, no respiration, no air movement, you are still going to shock them first. You are still going to shock first, no matter how many times they say that the V-fib is not breathing and has no respiration. Because you know what happens if you shock them? They come back to life. And there's nothing like being alive to make you breathe. Right? Right. Okay.